All right, our next topic and last one in this chapter on failed pregnancy is ectopic pregnancy. Ectopic pregnancy can be defined as a pregnancy with implantation outside of the uterine cavity. The most common location is in the fallopian tube, in the distal fallopian tube, but if it's outside the uterine cavity, regardless of where it is, that is ectopic. Most common location is in the fallopian tube. Here's our case. A 28-year-old woman visits emergency department with unilateral left-sided abdominal pain. I want you to notice unilateral pain. If it's bilateral pain, what do you think of? PID. Unilateral pain, you think ectopic. So she has pain. Number 2, she's got vaginal spotting. So she's got bleeding for 3 days. So we have pain, bleeding, and her last menstrual period was 8 weeks ago. Amenorrhea. When you have those 3 things, pain, bleeding, amenorrhea, your presumptive diagnosis must be ectopic pregnancy until ruled out. Her previous pregnancy was uncomplicated, term spontaneous vaginal delivery. Now, she had used an IUD for 3 years in the past. When we think of the etiology of ectopic pregnancy, PID is one of those. IUDs have been associated with PID. Could that have taken place? Don't know. On pelvic exam, we find the uterus is slightly enlarged. Can you have enlargement of the uterus even though there's nothing in it? Yes, you can, because of the hormonal effect. There is left adnexal tenderness. Could there be a tubal pregnancy? Yes. Now, you cannot palpate a mass, but the quantitative beta-HCG is 2,600 milli-international units. That's important to remember, because we're going to come back to the beta-HCG number. When you have suspected ectopic, we want to get a quantitative serum beta-HCG. Now, most of the time, ectopic pregnancy is unilateral, but here's an unusual case with bilateral tubal ectopic after natural conception. Generally speaking, once you've got a ectopic on one side, you're not going to get it on the other side. Now, notice where will conception take place? Right here, and we get migration of the zygote. Anything which obstructs the movement of the blastocyst or the morula, and it starts setting up housekeeping before it gets in the uterine cavity, will predispose to ectopic pregnancy. All right, let's look at what we're going to talk about. If you have amenorrhea, bleeding, and pain, you must suspect ectopic pregnancy. In the presence of tachycardia and hypotension, your diagnosis is ruptured ectopic, and the management is operating room right away, because this patient is going under. Let's say she has amenorrhea, bleeding, and pain, but no tachycardia, no hypotension. Then we look at what's the beta-HCG titer, and does transvaginal ultrasound show an intrauterine gestational sac. If the beta-HCG is less than 1,500, then you can't tell whether it's a ectopic or not. The management would be to repeat the beta-HCG in 2 to 3 days. If it was a normal pregnancy, what should happen to the beta-HCG? It should double. If the beta-HCG is over 1,500, then you say, can we see a transvaginal ultrasound and intrauterine gestational sac? If the beta-HCG exceeds 1,500, transvaginal ultrasound, no intrauterine gestational sac, your diagnosis is unruptured ectopic. How do we manage an unruptured ectopic? It depends on the gestational age. If it is early, we can use medical management using methotrexate. If it is more advanced, we will use surgical management, which would be laparoscopy. And just for ease of diagnosis, if the beta-HCG is less than 5,000 to 6,000, we will use medical management. If it is over 5,000 to 6,000, we will use surgical. The most common site of ectopic pregnancy is in the distal tube, 80%. It can be in the isthmic part of the tube. Cornual pregnancy is going to be difficult to diagnose because it's not outside of the uterus, it's not in the uterus, it's in the wall. Abdominal pregnancy is uncommon. Uncommon. Here we have an abdominal pregnancy, and you can see this is a uterus. Here's the uterine cavity, and we have implantation, development of the placenta on the outside of the uterus. Now, this is not going to be delivery by a cesarean because you don't need to open up the uterus. You just need to open up the membranes if she gets this far and deliver the fetus. Most of the time, this is not going to survive to where it'll be even viable. What do you do with the placenta? Don't try to remove the placenta because you're going to get into big time bleeding. Leave the placenta intact and give methotrexate. This is an ultrasound which shows an abdominal pregnancy. Let me show you a few lines that will help you tell what's what. This is the bladder. This is the uterus. And here is the fetus. You see that? This was from South America, where they allowed this to go because it was illegal to interrupt a pregnancy because of the prohibitions. This was the placenta, and you can see it's attached to the mesentery of the bowel. Here's a fetus. Very misshapen head because you've got pressure from all the external viscera. Here's a term asymptomatic abdominal pregnancy with good maternal and perinatal outcome. This is from Iran. Unusual to say the least. What do you think? I think this is Photoshop. Did you hear about the pregnant man? Mr. Lee. This is from CNN.com, the first man in history to become pregnant. You believe it? This was in 2001. This was a fraud. Never happened. But technically, I suppose you could implant embryos into a male. This is looking at cross-sections of the oviduct, proximally in the mid of the tube and the distal. And what I want to direct your attention to is the thickness of the muscularis. Proximally, it is very thick. As you get distally, it becomes thinner. This thickness of the muscularis is why most distal ectopics do not rupture the tube, because they can make it through the muscularis without difficulty. But the proximal tube will probably rupture. The differential diagnosis of a patient who has an ectopic includes threatened abortion, incomplete abortion, molar pregnancy. And how are we going to tell the difference between these? Ultrasound, speculum exam. We've already talked about threatened abortion, incomplete abortion, and we'll talk about molar pregnancy later on. Risk factors. Anything which obstructs the normal zygote migration increases the risk of ectopic pregnancy. This could be scarring or adhesions, either from an infectious cause, such as a PID, a woman who has had surgery on her fallopian tubes, tuboplasty, or if she had a failed tubal ligation, has a higher rate of ectopic pregnancy if she conceives. There'd be congenital scarring from diethylstilbestrol, where you have Müllerian anomalies. We talked about that earlier. But in most cases, there is no risk factor found, idiopathic. Now remember, if there is scarring, and if you preserve the tube, there's going to be a significant risk that you can have a recurrent ectopic pregnancy. Here is PID, and you can see the significant scarring of this tube. The tube and the ovary are all scarred together. In fact, as I look at this picture, I wonder, how did she ever conceive even with an ectopic pregnancy? The clinical findings, we already talked about this. Symptoms of an unruptured ectopic are amenorrhea, she's missed her period, vaginal bleeding, and unilateral lower abdominal pelvic pain. That's going to be your typical triad with an unruptured ectopic pregnancy. What will you find with a physical exam with an unruptured ectopic? Unilateral adnexal tenderness as you palpate, with a pelvic exam. Cervical motion tenderness. Now, why do you have cervical motion tenderness? The cervix is not actually tender. But as you move the cervix with your finger, it puts the tube on stretch. The tube is distended because of the ectopic, and that's what causes the pain. The other differential diagnosis when you have cervical motion tenderness is PID. So cervical motion tenderness, sometimes called the chandelier sign. As you move the cervix with your finger, the patient lifts up her pelvis toward the chandelier. Think of PID, think of ectopic pregnancy. Now, with PID, you'd have a fever. With unruptured ectopic, no fever. You're going to have an enlarged uterus, even with an unruptured ectopic. You're not going to have that with a PID. Now, if you take 100 patients who have amenorrhea, bleeding, and pain, what percentage do you think will have ectopic? Think it's going to be the majority? Studies have been done and found that only 10% actually of amenorrhea, bleeding, and pain will have ectopic. You may have an abnormal pregnancy, such as a missed abortion, a threatened abortion. We talked about that. But the majority are probably going to be normal intrauterine pregnancies. But ectopic is clearly the most risky, the most serious complication, so we need to rule that out. Anytime you have amenorrhea, bleeding, and pain. A ruptured ectopic pregnancy. The symptoms are variable depending on the extent of intraperitoneal bleeding and peritoneal irritation. If she's got large amounts of bleeding, if she is got a large bleed, she may very well be hypotensive and syncopal. The peritoneal irritation will depend on how much blood is in the peritoneal cavity as well. Signs: peritoneal irritation, guarding of the abdomen, rigidity if you've got a lot of peritoneal irritation, and depending on how much blood volume you've got, hypovolemia, hypotension, tachycardia. So ruptured ectopic is variable depending on how much blood you've lost. Diagnosis. The diagnosis of an unruptured ectopic is presumed when two criteria. Number one, beta-HCG titer is equal to or greater than 1,500 milli-international units. And number two, transvaginal ultrasound shows no intrauterine pregnancy. Now, transvaginal ultrasound is higher resolution. You can see much clearer. If you do an abdominal ultrasound, it's going to be a beta-HCG, which is 6,500 or greater. But nowadays, with the availability of transvaginal ultrasound, we use the 1,500. So if you've got a patient who has amenorrhea, bleeding, and pain, beta-HCG over 1,500, no intrauterine pregnancy on transvaginal ultrasound, your diagnosis is ectopic. Where is it? I don't know. The most common place is in the tube, but all I know is it's not where it should be, which is in the uterine cavity. The 1,500 beta-HCG international units is called the discriminatory threshold. The discriminatory threshold is the level of beta-HCG at which you should be able to see a normal intrauterine pregnancy with transvaginal ultrasound. Now remember, we talked about where does beta-HCG come from? From syncytial trophoblast. So early in the pregnancy, you have a small volume of syncytial trophoblast. The beta-HCG titer will be very low. As the volume of the syncytial trophoblast increases, the beta-HCG titer will also increase. And so we have doubling of the beta-HCG titer every 2 to 3 days. Now, at some point, the volume of syncytial trophoblast is going to be large enough to produce a beta-HCG which is large enough to see an intrauterine pregnancy. What will be the corresponding beta-HCG titer? 1,500. If you have a normal intrauterine pregnancy, you should be able to see it when the beta-HCG titer reaches 1,500. And that is what we call our discriminatory threshold. Here you can see a normal endometrial stripe, no intrauterine gestational sac. Cul-de-centesis was used in the past where you place a needle through the posterior cul-de-sac into the pouch of Douglas, and if there is a ruptured ectopic, you have free blood which you can aspirate. We don't do that anymore because most of our ectopics are picked up prior to a rupture. The other thing is, if you've got a lot of PID, the cul-de-sac may actually be obliterated, and even though you've got a hemoperitoneum, you put a needle in, you won't aspirate any blood anyway. So nowadays, with our sensitive transvaginal ultrasounds and our serum beta-HCG, cul-de-centesis is not done much anymore. Okay, how are we going to manage this? It depends whether it is ruptured or unruptured. If it is ruptured, you know we talked about amenorrhea, bleeding, pain, hypotension, tachycardia, urgent surgery. Usually we're going to do a laparotomy, get in there quickly because she's hypovolemic. Stop the bleeding, and you're probably going to take out the tube. What if you do the ultrasound and you find that there is an intrauterine pregnancy? Then you individualize management depending on what you've got. Is it a viable pregnancy? Is it a non-viable pregnancy? You're going to individualize. What if the beta-HCG is, say, 900, and you see no intrauterine pregnancy on ultrasound? You're unsure. Could it be an ectopic? Yes, it could be. Could it be a normal intrauterine pregnancy? Yes, it could. Since she is stable, there's no need to rush. Just repeat the ultrasound and beta-HCG in 2 to 3 days. If she has a beta-HCG of 900, in 2 to 3 days, it should be 1800. By that time, you should be able to see an intrauterine pregnancy with transvaginal ultrasound. So if a patient is stable and you're not sure, just repeat the ultrasound and the beta-HCG titer. All right, management of unruptured ectopic pregnancy. We have a medical management, we have a surgical management. The medical management is methotrexate, the surgical management is laparoscopy. The preferred treatment will be the cheaper one. And if you can get as good an outcome with medical management as surgical, go for it. And if you have an early ectopic, we will use medical management. How do we identify an early pregnancy? A simple way is just to look at the beta-HCG titer. If the beta-HCG titer is less than 5 to 6,000, that's going to be an early pregnancy, and the management is methotrexate. The mechanism is, it is a folate antagonist. Any rapidly growing tissue requires folic acid. And if you take away the folate, it's going to stop growing. Some people would say you should also do a D&C anytime you use medical management. That is not universally done. How do you know if the folate antagonist, the methotrexate, has worked? You've got to do weekly beta-HCG titers. And you want to follow that until the beta-HCG titer becomes 0 or undetectable, which is typically less than 5 million international units. Always remember, if she is Rh negative, she may need to get RhoGAM. If the beta-HCG titer is over 5 to 6,000, it is less likely to respond to medical management, and this will then require surgical management, which is usually laparoscopy. If you've got a stable patient and you can do a laparoscopy, do it. The most common procedure which is performed is a salpingostomy. Ostomy means you make an opening in the tube. You then dissect out as much of the trophoblastic tissue as you can. How do you know if you've got it all? You're going to have to do weekly beta-HCG titers to make sure that it drops down to 0. Now, what if she was 38, 40 years old, she's had 4 children, and she had a tubal ligation which failed? What will she want you to do? She'll want you to do a salpingectomy, take the tube out. So I like to ask the patient if she is stable and unruptured, What do you want me to do when I get in there? Do you want to preserve the tube, or do you want us to take it out? This is the most common site for an ectopic pregnancy in the distal tube here, and you can see it is unruptured. You make a linear incision, either with a scalpel or with a bovie. You then dissect out as much of the trophoblastic villi as you can. You don't need to close the incision. It will close on its own, or you can close it if you want. And remember, you've got to do serial beta-HCG titers to make sure that it is, in fact, all gone. This is a photograph, actually showing making the salpingostomy, and here dissecting out the trophoblastic tissue which is there. This is your salpingostomy. This is your salpingectomy, if she wants the tube removed, or if the tube is damaged beyond repair. Then you will burn, cauterize through the mesosalpinx. You will amputate this part of the tube and refer this. If she's got tubes which are so damaged that they are non-functional, if she wants a pregnancy and she will need intra or IVF, in vitro fertilization, then she will have a better likelihood of success with IVF if you take the tubes out. Salpingectomy. All right, I want to show you the smallest patient that I ever had. I had a patient who I operated on with amenorrhea, bleeding and pain, stable, laparoscopy, and what did we find? This is what we found in the tube. Here you can see is the eye. This is the head, the limb buds which are here. This was a 7-week ectopic. This is from an embryology book showing the approximate gestational age. What was tragic here is the heart was beating, but there was nothing you could do. Here is the clot from the bleeding. How many women would love to have this transplanted into their uterus? But there's no way you can do this. Ectopic pregnancy, 7 weeks gestation. This is an ectopic pregnancy of 8 weeks gestation. And this one is unbelievable, a 10-week ectopic pregnancy. Usually by the time you get to this point, the villi have invaded into the blood vessels, causing hemorrhage, and it never gets this far. All right, let's review what we have just said. The triad for ectopic pregnancy: amenorrhea, bleeding, and pain. If you have hypotension, tachycardia, ruptured ectopic, to the OR, operating room. If she is stable, we want to do a beta-HCG and transvaginal ultrasound. If the beta-HCG is less than 1500, repeat it in 2 to 3 days and see what happens. Remember, we talked about if you have failure of normal increase of the beta-HCG, that's evidence of a pregnancy that's not going anywhere. If you have a beta-HCG over 1500, transvaginal ultrasound shows no intrauterine gestational sac. Diagnosis: unruptured ectopic. Management will depend on gestational aid. Medical management would be methotrexate, folate antagonist. Beta-HCG, less than 5 to 6,000. We need to do serial beta-HCGs to make sure that the trophoblastic tissue has in fact been destroyed. Surgical management would be, if you have an advanced ectopic, beta-HCG over 5 to 6,000. If you see cardiac motion, that's equivalent to a 15,000 beta-HCG. If the size of the mass is greater than 3.5 centimeters, that's not medical management, that must be surgical management. So we're going to do a laparoscopy and take care of it that way. Here is another just quick review using an algorithm for ectopic pregnancy. And remember, we start out with amenorrhea, bleeding, and pain. If you have amenorrhea, bleeding, and pain, hypovolemia, guarding, rebound, ruptured ectopic, management, emergency laparotomy. No question, you got to get in there pronto. If it is if there is no hypovolemia, guarding, rebound, if the patient is stable, you always need to think of other etiologies: reproductive tract, GI tract, urinary tract. Could there be torsion of the ovary causing pain? Could there be PID? Could it be an appendicitis, pyelonephritis? Always think of there's 3 organ systems in the pelvis. There's the GI tract, the urinary tract, as well as the reproductive tract. Let's say we have ruled out these other causes. Now we're concerned about unruptured. If the beta-HCG is less than 1,500 million international units, which is our discriminatory threshold, what we will do is repeat the beta-HCG titer in 2 to 3 days. Okay, the beta-HCG is over 1,500. Now, can we see an intrauterine gestational sac? If we can, intrauterine pregnancy, and we're going to individualize with whatever we find. If there is no intrauterine gestational sac, beta-HCG is over 1,500. We assume it is an unruptured ectopic, and we're going to manage it according to gestational age. If it is an early pregnancy, less than 6,000, methotrexate. If it is a later or advanced pregnancy, over 6,000 beta-HCG, laparoscopy. And that finishes ectopic pregnancy.